Hello class, today we're going to be talking about pump failure. It's going to be our micro-learning session for today. So some of our learning objectives as we're looking through these today, we're going to be learning about the difference between heart failure with a preserved ejection fraction versus heart failure with a reduced ejection fraction. And we're going to look at these from what's going on with the patient, presentation, how we treat them, the signs and symptoms, what we're going to do to figure out, hey, what is their EF? And then we're going to look at our nursing interventions and medication considerations specific for heart failure. So first thing I wanted to do is kind of review some of the anatomy going on here. A lot of you might have been taught, we have right-sided failure, right, and then we have left-sided failure. And this is something that's really changed really since like 2016, I would say. But in the last guidelines that came out in 2022, we've really stressed that the right and left don't matter as much as the amount of blood that's actually coming out of this ventricle. So we measure this down here to look at our ejection fraction, right? Our ejection fraction. The amount of blood that comes out of that left ventricle every time it beats. So throughout the day, you have tons of heartbeats. The amount of blood that ejects out of there goes actually up through here, through the aorta, and out to your body. So if you need a review of the anatomy, that's why I put this here. When I'm talking today, when I say that we're looking at the ejection fraction, I'm looking at how much blood is coming through the left ventricle, up through the aorta, and out to the body. So what is heart failure with preserved EF? So heart failure preserved EF is a type of, this would be our right side if we were to talk about this, but it's a type of heart failure where the heart muscle is stiffened, meaning it can't relax, and cannot relax properly, impairing the heart's ability to fill. So as our heartbeat continues to contract, we have good output of our blood. When it goes to fill up, it doesn't fill up well because it's so stiffened. So the EF is normal or near normal. So the amount of blood that's still going out is near normal, but the diastolic filling is what we're having an issue with. So the amount of blood that's coming back into the heart, leading to a poor cardiac output. And then if you remember back, this is where when we learned right failure, this is where our patient not having good output, the patient's going to have body demands that are not meeting the needs. So what are they going to look like? This is where you have your edema, lower extremity. You could have easily fatigable, all those things. What are the causes? Often is hypertension. Why does hypertension cause this? Because the amount of pressure that we're putting on our heart causes the muscle to build. Just like if you were doing weights and you're building at home, when that muscle builds, we don't necessarily want it to be building towards the inside of the heart or causing the heart to stiffen. And hypertension makes the heart stiffen because it has to work so hard, the muscle contracts so much. Diabetes, obesity, if we have a small heart trying to pump a big body, that's going to cause some issues. Aging, of course. So what is the difference between preserved versus reduced? All that really is telling us is what is the ejection fraction. So this is when our ejection fraction is less than 40%, with normal being greater than 60, and the left ventricle is weakened. This is where you've commonly learned left failure. So why is Dr. Moser stressing to know these terms? These are the more appropriate terms that you'll see clinically. This is what we do for billing purposes. This is what you'll really see a lot of clinicians using because it stresses the value of EF rather than left versus right because most of the symptoms overlap. So symptoms include here, you see them here, fatigue, fluid retention, edema, increased oxygen demands. And all of these are going to be caused by similar things. You see them here at the bottom: coronary artery disease, MI, cardiomyopathy, and chronic hypertension. So all of those can lead to it. And many times you're probably taught, and this is correct, right-sided failure leads to left. It's the same the other direction because as we have all this fluid buildup and we have this weakening heart, it can cause both sides of our heart to fail. So what medications are we going to give for heart failure? This is a term that if you haven't seen it before, it's good to go look up. Guideline-directed medical therapy or goal-directed medical therapy is basically what we do to improve survival of heart failure patients and their quality of life. So these guidelines came out in 2022. So at the time of making this PowerPoint, they're 3 years old. we do a multitude of medications in order to treat these patients. Some of these you may have already heard of, such as ACE inhibitors like lisinopril, ARBs like losartan, beta blockers like metoprolol. Those are some of the main treatments for reduced EF. So what is the main treatments for preserved EF? The biggest one is actually going to be diuretics. Why is it diuretics? Well, if we go back to our picture of our heart, and you think about we're having a preserved EF, so the amount of blood going out is still good, but this part of the heart is not doing well. Well, where is that going to back up? Back into central circulation, right? So we're going to have a high preload, an elevated preload. How do we get rid of that? Well, we get rid of that through doing diuretics. So many different types, but diuretics are the main treatment. Aldosterone antagonists, they have other names too, mineralocorticoid. This would be like our spironolactone, SGLT2, these are the TV ones, the great ones on TV like Jardiance, which is not just for diabetes, it's also for heart failure. And then we have newer additions like our combo drugs that combine multiple medications. So the guideline-directed medical therapy goal is to help our heart failure patients have a good quality of life. And this is what most of our teams, our heart failure clinics, are really following. So some NCLEX questions. What are we going to be asked on heart failure? Well, a nurse is assessing a client with heart failure. Which of the following findings is most concerning and requires immediate intervention? So what this NCLEX question is asking you to do is figure out what is the worst symptom the patient's having or exam finding, and that we have to do something immediately. So 2+ edema, blood pressure 88/54, weight gain of 2 pounds in 2 days, crackles in the basis. So think about this for a second. When you're looking at it, the weight gain, positive sign of heart failure. The crackles in lungs, positive sign of heart failure. The 2+ edema, positive sign of heart failure. The blood pressure of 88/54 could be a positive sign of heart failure. But which one would show that the patient is decompensating? So they may always have edema. They may always gain some weight. That's not too much, 2 pounds, 2 days. They may have some crackles. But the most concerning finding for their heart failure getting decompensated is if they're not making a good output, right? A systolic that's pretty low. So B would be the most concerning finding there. The nurse is providing discharge teaching to a patient with heart failure. Which of the following statements indicates a need for further teaching? So if you guys remember, what are we looking for? When we see further teaching, we're trying to find the wrong answer. What's wrong? I will weigh myself every day at the same time. That sounds pretty good. I will take my beta blocker even if I feel fine. Sounds pretty good. If I gain 3 pounds in a week, I'll let my provider know. Okay. I can stop taking my diuretic once the swelling goes down. Ooh, remember, we don't ever want our patients to stop taking meds until they call us. So D would be our correct answer. It's always tough when we're trying to find the wrong thing as the correct answer, but that's just how sometimes it's asked. Need for further teaching. So some key takeaways from today. We're going to monitor for medications, assess how well the patient's taking their meds. Are they on their ACE inhibitors? Are they on their beta blockers? And we want to keep them out of the hospital. So this is why heart failure teams have been developed, and they're very common here in Central Florida. We're going to manage their fluid levels through the use of diuretics, and we're going to monitor that they've been effective both by daily weights and then looking at our patient. Do they have bilateral edema that's getting worse? Are they have anasarca? Is their belly swollen? We're going to teach them how these new treatments are coming around, specifically like SGLT2s with our Jardiance, where those can really help limit heart failure exacerbations, and why the patient's on a diabetic medication, even though they may not have diabetes. And then we're going to personalize our care, and this is so important to us as nurses because we want to make sure we're giving optimal care and treating every patient individually based on their cultural preferences, their diet, and what we can do for them. Hey, thank you so much for joining me today.